Good afternoon, everyone. Just rolling in. Appreciate you attending our webinar on fee schedules. We're going to wait a few minutes till we have everyone in the attendees that are going to be here. So just give us a minute or so and we will kick it off. And again, for those of you just still rolling in, we're gonna just giving it till the top of the hour so everyone can get in that we're expecting. So thank you again for attending. Good afternoon, everyone, and welcome to today's webinar, a 2021 perspective on fee schedules. My name is Alex King. I will be the host for this webinar and will be helping field questions to our presenters throughout this presentation. Before we get started, I just want to say to everyone, thank you for attending our webinar on fee schedules. We're glad to see that people realize the importance of fee schedules and are still interested in learning about this subject. We will be doing more webinars on additional data solutions, such as bill review, content management, and business intelligence as the year goes on. So please be on the lookout for those in the future as well. But as far as today's webinar on fee schedules, the topics that we are going to be focusing are reviewing the current fee schedule landscape in 2021 and talking through recent changes and trends, such as COVID-19 and the Michigan auto fee schedule. We'll also talk through the impact and importance of timely fee schedule implementations, along with ways to analyze your current program and tools that are available to keep you informed on what's going on in the world of fee schedules. I would now like to introduce our presenters, Mr. Jonathan Nutt, Chief Technology Officer. Mr. Nutt joined MEDICARE as CTO at the beginning of 2020, bringing operational and change management expertise to our leadership team. He spent 25 years at AIG, where he helped develop medical management operations both globally and domestically. We also have Mr. Todd Brown, Practice Leader, Compliance and Regulatory Affairs. Mr. Brown has 34 years of experience in the workers' compensation industry, creating standards for reporting information to state regulatory commissions and creating fee schedules. His experience includes serving as Deputy Director of the Florida Division of Workers' Compensation, as well as Executive Director of the Texas Workers' Compensation Commission. Finally, Ms. Lisa Andriosi, Technical Lead, Fee Schedule Business Analyst. Ms. Andriosi has been with MEDICARE since 2015 and has over 2 decades of experience in the healthcare and insurance industry. She specializes in fee schedules and has an extensive knowledge of bill review. She is well known as a MEDICARE expert and has a proven career of innovation in product development. Now, before I kick it off to the experts, I would like to go over a few items on how to interact during this presentation. Audio is muted, as you can tell. However, we will have the opportunity to submit questions to today's presenters by using the Q&A feature, which we will be monitoring and answering those questions throughout the presentation. So I'd like to get things started now and kick it over to Mr. Jonathan Nutt.
Thank you, Alex. So let's start by taking a look at a review of what's out there in fee schedules and what potentially is new on the horizon. If we look at the fee schedule, there are 52 workers' compensation jurisdictions if we include the District of Columbia and the official workers' compensation program. 48 of those have a fee schedule, and there are also 7 auto jurisdictions that have a fee schedule. That probably doesn't come as a surprise to anybody, but if we look at this and really think about what fee schedules are, there's more than just I have a fee schedule and I don't. If I look at it based on fee schedule publications, many people would say to you, oh yeah, I understand, there's medical provider, there's facility, and there's pharmacy, the 3 different types of fee schedules. Those who think about it a little bit deeper will probably come up and say, oh, well, in medical, you've got CPT-based and you've got HCPCS-based, in facility, inpatient and outpatient, and you still have pharmacy. But in reality, if you look at it based on the different types of fee schedules that are published by states throughout the country, there are 17 different types of fee schedules that are published. Obviously, that's significantly more than the 3 or even the 1. Looking at that and trying to see what's happening with the states, you will see, if I look at it from a real broad perspective, Colorado is the only state that publishes all 17 fee schedules. There are 4 states, Iowa, Missouri, New Jersey, and New Hampshire, which publish no fee schedules at all. In those states, you are totally at the mercy of a usual and customary application. But again, there's obviously more to it than that. If I look at it, the medical provider, which really is physician and clinical lab, what we'll see is that there's an additional state that doesn't actually address this in a fee schedule at all, Indiana. We have other states where they are not addressing the clinical labs, but the good news is, since this is the area that covers the majority of the bills that come through your operation, most of the states do have some kind of a fee schedule in this area. Moving on, if we think about the HCPCS-based fee schedules, the ones which have the primary impact on you in terms of dollars are DME, the J-code drugs, and home health. So if we look at which states have the different areas covered, what you will see is there are very few in blue that have all of those HCPCS areas, all 6 of them covered. If you look just at the ones which have all of the 3 primary spend areas covered, you'll see again, we have relatively few. We only have 3 of those. We get better when we come down to 2 primary spend areas. The thing I will tell you is, if you look at, most of them have DME covered, but the ones between the other 2, which is not covered, there is no consistency between them. There are a lot of states that have some, but you can see a lot more states where we have nothing covered at all in terms of this type of fee schedule. So moving on, when we look at the facility, inpatient and outpatient, we take a look at the states which have some kind of a fee schedule there. We have 4 states now which have dropped in and don't have any kind of fee schedule: Wisconsin, Maryland, Arizona, and Hawaii. So you'd look at it and think, yeah, so there's a gap there. But if you look in more detail at this, there are a lot of states out there which are still using a percentage of charge. Obviously, that's a significant difficulty, because if a provider increases their charge, they're still controlling the amount that they're getting paid. So there's a restriction there on the real effectiveness of that type of a fee schedule within the facility arena. And these states may not all have all of these areas covered in that way, but each one of the states that is highlighted there has something within this part of the fee schedule that's covered as a percentage of charge. If we move on and look at the inpatient area and think about the fact that rehab, long-term care, and skilled nursing are things that you might think they're very similar. So if a state has addressed one of those, they will have addressed all of them. When we look at the reality of it, that's far from the truth. Many states have covered rehab, but if we layer over that the long-term care, you will see that only some of those states have covered long-term care. And the interesting thing is that there is no state that has not done rehab that has done long-term care. And when we overlay onto that the skilled nursing combination, you'll see a large variation there. Rehab is the only thing covered in some areas. In some areas, skilled nursing is the only thing covered. And there are only a few states which are covering all 3 of those areas. So really what this brings to highlight is that there is no consistency in even those things where you think they are very similar types of services. Finally, we take a look at the pharmacy area. And in pharmacy, again, you might think we have states are a yes or a no. We have a significant number of states which have other types of fee schedules which have not covered pharmacy at all. But even within the pharmacy arena, we have different ways of dealing with that. California uses the MEDICARE numbers in order to price to fee schedule. Many of the other states are using Medispan, but still others are using Redbook. Since things are primarily based on an AWP, there are different ways of actually evaluating that, and different states use different amounts. So even in a pharmacy arena, we're seeing significant variation, which all of that means that comes down to the fact that it's more work to actually maintain this and keep it all up to date. Finally, if we think about this from an exposure perspective, at CPT, the primary dollars are in physician. In the HCPCS world, it's DME. In the inpatient world, acute care is where we spend most of our dollars. Both of the outpatient arenas and pharmacy, all of those things make up the majority of the medical spend. And looking at that from a state perspective, we've tried to provide a gradation here of where the exposure is and how they're covered. So the blue areas are the ones where we have a very good coverage on the major areas where there is expenditure. The four which show up are the initial four with none as red, but you have several states there where there are significant failures to cover any of the, or some of those major areas. So clearly there's a lot of opportunity within that, the range to actually address some of those issues and provide better control over some of those medical costs. Lisa, would you like to take us into a story about Medicare-based fee schedules?
Yes, thanks, Jonathan. So I wanted to point out that back in one of our first slides, we saw that there are 48 jurisdictions that have workers' compensation fee schedules. And of those, 41 of them have utilized Medicare to some degree to produce their own fee schedule. What this map represents is all the states that have tapped into or borrowed from Medicare in some capacity. Some examples are using the RBRVS, which is Medicare's physician fee schedule, to produce their own fee schedule, adopting Medicare's DME POS rates to establish rates for durable medical equipment and supplies. Another area that's becoming very popular is using Medicare's ambulatory payment classification data to pay for outpatient and ambulatory surgery center payments. And a lot of states use Medicare DRGs to determine inpatient admission rates. So what do the other 7 states use? Some use relative values for physicians, which is a proprietary publication produced by Optum, so it costs money. Some contract with private vendors to produce their rates and rules. What I want to point out is what's not shown here, and that's that there are 7 auto fee schedules. There's an 8th one coming up this summer, which is Michigan. And of those 8, 6 of them use Medicare in their fee schedules. So what's the significance of using Medicare? What's the impact of using Medicare? And why are you seeing this information today? Well, the purpose of sharing this information leads us into our next slide, which illustrates the number of fee schedule updates per year. So you see, there's not a lot of states where you just have one update and you're done. Our final picture is actually that there are 48 states that have workers' compensation, or 48 workers' compensation fee schedules. But the statement can be oversimplified because there's a lot of content and detail within those fee schedules. There's actually a lot of updates required to stay compliant, and it's especially true for those states that use Medicare. Medicare updates frequently. Most of their fee schedules update quarterly. So you're looking at a minimum of 4 times per year. Medicare has a lot of retroactive updates, and they do a lot of corrections. On the next slide, we see some similar information, but from a different point of view. Now, this graph shows us the fee schedule updates for the last 9 years and why the steady increase. A lot of them are Medicare-based fee schedules, so that can account for some of it. Specifically in 2020, we had COVID. We had the AMA putting out new CPT and HCPCS almost on a monthly basis to represent COVID testing, different types of test kits and testing codes, different treatment codes. And then they started putting all the vaccinations, and each manufacturer has its own CPT or HCPCS code for their vaccination. So there's been a lot of those updates. a lot of jurisdictions have been revamping or introducing telemedicine guidelines, which accounted for a lot of the updates as well. And again, state corrections. We see states correct things all the time. They're humans just like everybody on this call, and people make mistakes. So when they find a mistake, they have to fix it. And in turn, you have to fix it in your system as well. So one thing I don't want to forget to point out is that 49% of those updates last year were released after the effective date. So it takes a lot of work to stay compliant. So next, Todd and I are going to talk about the different areas that we're likely to change. So I've coined the whole Medicare thing as the Medicare movement. And there are some really good reasons why people use Medicare. Some of the benefits is that the federal government is spending millions of dollars each year to maintain their program. They are continually analyzing healthcare trends. They review expenditure. They're looking at quality of care. So much as the quality of care, they've actually introduced for most of their facility payment systems that if a hospital has too many readmissions, they will actually deduct money from their future payments until they get their act together, so to say. So they're really looking at how are patients being treated and are they being treated before discharged. They also look at treatment guidelines. They recognize emerging technology. And since their research, it would be extremely difficult to dispute or discredit their results. All this makes for a very strong foundation for a fee schedule. My favorite, I'm sure it's everybody's, it's free data. It's available on their website. It has no cost to anybody. Anyone can go to their website and download the data. It's updated daily. So you have up-to-date free data. Now, there are two areas that I think are cons where Medicare is not a good fit for work comp or auto claims. And number one is that Medicare's core population is people over 65. So their coverage policies or limitations are not in the best interest for treating workers' comp or auto injuries. Another thing is they have very specific coding and billing guidelines. And those guidelines sometimes deviate from nationally recognized standards of billing that we see in the private sector. So one of my favorite examples is modifier AT, and that stands for acute treatment. And Medicare, they will not pay for maintenance therapy when it comes to chiropractic treatment. So they require that anything that's billed by a chiropractor has to be billed with modifier AT, or else it will not be paid. If we were to take that kind of rule and put that into work comp or auto, we could see a lot of reevaluations just because the modifier is not there, but the treatment is medically necessary. So that's an area, again, where their coding and billing guidelines really don't mesh with the private sector. And so it's not a good idea to incorporate this into a work comp or auto fee schedule. So what usually happens is that most state agencies only adopt Medicare payment rates. They recognize that the policies would actually hinder reasonable and appropriate treatment and actually cost people more money trying to jump through hoops to get to where they need to be. So there's also areas where Medicare they don't address it because of who their core population is. And some of those examples are work hardening and disability exams. They also don't have anything for prescription drugs. So those are areas that a state agency would have to gap fill if they're looking at using Medicare for their fee schedule. So I believe we're going to see more and more integration to Medicare over the next few years. So we look at how are states looking at new fee schedules? Are they looking at new fee schedules? Well, we have 4 states that still don't have any. Now we have Iowa, Missouri, New Hampshire, New Jersey. The last time a fee schedule was adopted was, Illinois way back in 2007, and then more recently, Virginia in 2018. Well, the latest one is Michigan Auto, and this is the 8th state to adopt an auto fee schedule. It is Medicare based. They didn't really specify what to use for Medicare, But they said where Medicare does not have a payable amount, then reimbursement is at a percent of charges. So that's huge because we wonder, well, what is charges? Well, they defined it as the amount the provider billed for a service on January 1, 2019. And I know they put that in because of cost containment. They don't want a provider to go, oh, I'm going to get a percentage charge for this particular service. So now I'm going to up my charges for, starting in July 2nd, 2021. But the flip side of it is how are insurance companies or any payer supposed to know what that provider charged on January 1st, 2018? And how are they supposed to collect that data? How are they supposed to maintain the data? It's a big gap that we're now seeing a lot of discussion on. Last week, the Department of Insurance and Financial Services issued some proposed regulations to put on top of the adoption or the regulations that were already adopted. So we're hoping to see some movement. They also identified that they're going to post a notice for public comment soon. So again, we need some more information so that everyone's following the same process. And that's an important thing with any fee schedule. Everyone needs to have clear instructions so that they can all follow the same process. We still have some major gaps to fill. Indiana still doesn't have a physician fee schedule, which is a huge cost area. And we have states that don't have facility fee schedules like Arizona. And we still, as Jonathan pointed out earlier, we have states that use a percent of charge for facility reimbursement. And as he pointed out too, it allows providers to control their own reimbursement amounts. And it doesn't save money for insurance companies. The insurance companies are going to pass that cost off to their policyholders, which are employers. And in the auto sector, they're passing that off to the drivers, people who have cars. So all of it's going to cut somebody money. And the thing is, we want to drive down the cost, not up the cost. So now I'm going to turn it over to Todd, and he's going to talk about the latest in medical practices.
Thank you, Lisa. Medical practices are another facet that you have to stay on top of. Fee schedules, the states publish those, you get them, but each year the CPT codes have increased codes, diagnostic codes are changed, and you have to stay on top of that. Not only on top of that in terms of they're the new codes, but how do you price them? How do you pay them? The several examples where states were lagging in that. There was a state that adopted the 97 CPT codes and did not update to the new version until 2008. So what you had was providers billing really acceptable codes, but they couldn't get paid because it wasn't a legitimate code in the fee schedule. Some states require legislative action to update the treatment guidelines. Other states have literally set it in statute that the state will adopt the new CPT codes. There are new techniques. Several years ago, states started looking at telemedicine in the workers' comp arena. The IABC had several sessions at their conferences that discussed that. Several states adopted telemedicine. But what we saw this past year with COVID, several things happened. First of all, you had codes that were being developed. How do you treat? What do you do? What's the testing? But the other thing that happened with COVID is all of a sudden, injured employees could not go in to see their provider. They were prohibited from that. You couldn't get treatment as regularly as you used to. And so what happened this past year was a number of states really escalated the adoption of telemedicine and using it. Some states actually adopted rules within the workers' comp regulations. Other states would put out bulletins giving guidance on that. And so what you had very quickly, in a period of about 3 or 4 months, the industry moved very quickly to be able to deal with the pandemic that we had. Another issue that's come up in the last several years is the use of opioids. And that's caused problems in the industry. I can remember back in early 90s, medical represented 20 to 25% of the cost of a claim. Pharmacy represented about 2% of that. Starting in 94, when the FDA off-labeled opioids, we saw that crisis starting to grow in comp as well as across the country. And if you look at it today, pharmacy represents anywhere from 15 to 20% of the cost of a claim. And that was really driven by the opioid crisis. So what states have done, and we've seen this happen with regularity, states have actually adopted formularies. Now, a formulary doesn't control the price, but the formulary does control whether or not that drug is appropriate in the treatment of the injured employee. And so you have those types of tools out there that allow you to better manage. But even it's not just, is it appropriate? You also have to look at how you manage denials, how you guide the person, the injured worker, or assist them in finding ways to get treatment and get pain-free. So those things are constantly changing. The industry has been slow to adopt, but it proved this last year when it needed to adopt quickly, it could.
Thanks, Todd. I appreciate that. We're going to get to some questions here. And then once again, for everyone online, please submit any questions that you have using the Q&A feature. First question I have, with pharmacy being 10-15% of spend, is there a difference between the Medi-Cal, Red Book, Medispan, et cetera, fee sets?
We get this question a lot from insurance companies when they're trying to figure out what should they use. Some states mandate that you use Red Book. Some states mandate that you use Medispan. California says use Medi-Cal first. I like to equate them all as like they're burger chains, and they all offer the same type of products. They have the similar ingredients. They just have proprietary recipes. So they are all very similar, and it just comes down to preference.
Next one we'll go to here. If you could only look at one fee schedule type of the 3 fee schedules, Medi-Cal, hospital, pharma, what is one to most focus on for reform?
So the most likely one to focus on for reform is one with the biggest gaps. We notice when you look through that, there's a lot of exposure in the facility area, and there are a lot of opportunities. Lisa talked about the difficulties with a percentage of charge in the detail there. You've got states that don't have it. You've got a lot of states with percentage of charge. That would be my take on that.
Yeah, I agree that the facility bills are outrageous. And I think if anyone's ever themselves just been to the ER for something like they hurt their foot, or, I got bit by my dog, and the spending is, or the charges are astronomical. And that's an area that we really need to have more cost containment.
Yeah, just one other thing. I noted articles recently that because of this past year, hospitals have really cut their profits considerably. So expect that to be something to really watch for going forward. Facility costs are going to be skyrocketing over the next 2 years.
What drives fee schedule changes?
I think the rising cost of medical care, in the insurance companies, they see that cost and they're the ones that are going to pass it off to somebody. So I think anywhere where you have that high spending and you see high cost, people are going to make noise.
The reality of this, Alex, is that as you look at what's happening, how premiums are actually calculated, in the workers' comp world, they're driven based on cost and what the losses are. And what that means is that people are eventually going to start to complain about that. And the employers who are getting those increased costs added into their premiums, that's going to be what drives things. So they're the ones who are going to be looking at that and ultimately be able to complain and do something about it. But the regulators have to be prepared to make the change.
As a payer, what can my organization do to fill in the fee schedule gaps?
I think we just touched on the primary issue, right? The regulators need to make the change. The people who are primarily impacted are employers. So from a regulator perspective, there's a real benefit there. The people who are bringing employment to your state and to your citizens are the employers, and they need to be able to get insurance at a rate which is reasonable. So being able to talk to the regulators, being able to get the employers to talk to the regulators and talk about what the impact is on their ability to provide employment in the state is a primary issue.
I would also add, Jonathan, that if you're in a state that doesn't have one of the major components, it's not going to be a quick fix. It will take several years to actually get it accomplished.
And then one last question here before we move on. What state has the most progressive fee schedule?
Well, if I look at a state that's really trying to address all of the cost factors, that would be Colorado. They have all 17 fee schedules, and they're very progressive in how they give carriers tools to properly manage medical bills. So I would have to say, while there's other states that have close to what they have, Colorado has been a leader in a lot of areas over the last 10 or 15 years in terms of medical management.
Awesome. Thank you guys for answering those questions. I appreciate everyone submitting those questions as well. We're going to move on now to section 2, and Todd, I will toss it back to you.
All right, this next section we're going to talk about is the impact and importance. First of all, what are the factors that affect delivery to payers? And then also the importance of timely implementation. So if we could go ahead and move down, the factors that affect delivery to payers is reality. What you have to do is you literally have to monitor what's going on out there. It is a constant process. We do it on a daily basis, but you should be out there at least weekly, checking what's happening, looking what states are getting ready to do, looking what states are finalizing on, being aware of what's occurring out there. And it's not just the regulatory arena. You also need to monitor the legislative arena. You don't want to be caught short with legislation passing that really changes your workflow or your business model because of legislation that's changed. The other thing is state notifications. And all the states provide notifications in some form. Some states are much better. They give you plenty of warning that a change is coming. They're getting your input on the changes. And they are, when they adopt, they're giving you adequate time to implement the changes. The volume of changes really is what drives the factors that you need to be monitoring. If you look today, we have 2 months out of the year that we consider sort of Armageddon. One is January, the other is July. Seems like most states point there to make their changes. And so you've really got to be on top of your game to be able to handle those changes when they're coming and handle them in the appropriate way. So if we, and all this really goes to the importance of medical in the arena today. And I think Jonathan's going to cover that on the next slide.
So as we look at what's happened with medical over the last few years, over the last 20 years, back in 2000, medical represented just over 50% of the total amount. If you look at what's happened over the last 20 years, there's been a consistent and steady increase. So that is now representing approximately 60% of your total losses, just below that. And this is data which has been used and with permission of the NCCI. So as you look at what that means, obviously, as the medical cost represents a higher proportion of your losses, it's going to be a more important thing for you to be able to address and take care of. So what does that really mean in terms of the impact and risk to you as a payer? Payment accuracy is an important thing, because what's going to happen? You're going to get overpayments and underpayments if you don't get the fee schedule correct. Typically, what I like to talk about there is that, most of the time you're going to get a complaint if there's an underpayment. An overpayment won't necessarily lead to the same thing, but where there is an underpayment and it's identified, you're always going to have to pay the additional amount. So obviously what's happening there is if the fee schedules aren't applied correctly, you're going to end up paying more than you should be. In addition, if you have these types of underpayments, that's going to lead to disputes, and disputes may cost, and always, at some point you're going to hit attorney fees. All of those things are costs that, are part of the workers' comp system that we always try to control. If you think about the fact that the reconsiderations are going to come in, those reconsiderations cost you time and resources. Not only are you making additional payments where they're required, but typically what's going to happen is if you're doing your own bill review, what you're going to see is you're spending a lot of time on just reprocessing those bills. If you're doing your own bill, if you have somebody else doing your bill review, but you're making payments, you're still incurring the costs of issuing another check, reviewing that, and making sure that the payment is correct. There's always a risk to payers of complaints at the state level, of regulatory complaints, of things being filed in California, for example, somebody filing for more IBRs, but also complaints to the state level. We all have lived in that world. We know that one of the things that becomes a problem is when a regulator gets his sights on you. Last thing that we want to happen. And finally, there's more general reputational risk. Yes, there are penalties, and those penalties are obviously going to have an impact, but also there's client awareness. It doesn't do you well in the market when there's a blog out there that says insurer 123 has now has 11,000 violations and counting. That's something that you want to try and avoid. It's not going to help you in trying to get new business, and it certainly doesn't do anything to make you look good. But what does it mean if there is no fee schedule? Well, we decided to take a look at this. We all know that there's a difference, but how big of that differential can there be? So what we did was we decided we'd look at two areas, one in New York, one in New Jersey. Both of them are proximate to Manhattan. So they're geographically similar, economically similar, and they both have the same type of environment, but one of them has a fee schedule in New York and the other one in New Jersey does not. So we started off taking a look at the higher volume things, looking at a mid-level office visit and a telemedicine visit, and you can see that there's a significant difference between a New York zip code in that area where you've got an $88 amount for that mid-level office visit, and the same thing for that particular area in New Jersey where it's $250. Telemedicine shows a narrower gap, but there is still a gap there with $123 and $173. Those are the high volume ones. If you think about the number of office visits that are happening, the inability in New Jersey to control that is going to give you a significantly higher cost. So we also looked at the high dollar value things, the things which have an individual large impact. Two spinal surgeries, both of them we looked at in ASC locations, again within those same zip codes. One of them, $2,739 in New York. And just for perspective on whether that's reasonable, the Medicare value for that is $1,671. So we have a significant markup on Medicare, which is supposed to be cost plus a small markup. So this is not an arena where the costs are being significantly driven down to a ridiculously low level. But in New Jersey, that same code would have a usual and customary of $81,000. Now, not all things are that big. The other CPT code we picked has a $4,300 New York fee schedule and approximately $43,000 in New Jersey. And what's scary about that is when you actually look at it, I'm saying it's not that bad, but it's 10 times the amount. So Alex, I'll hand it back to you.
Awesome. Thank you, Jonathan. A few questions we got here. Do fee schedules really have an impact in controlling or directing costs?
Definitely going to have an impact in what you're paying. The reality of it is that, where we've just seen that in that New York, New Jersey example. But there's obviously a bigger picture to that when you look at claims as a whole. Todd touched on utilization and how that's important. Controlling utilization and getting appropriate services is just as important as actually the amount that you pay.
And then kind of going off of that New York, New Jersey example, the ASC showed big differences between the two states. Was the New York cost better controlled because of New York's adoption of the 3M EAPG program?
I would say, Alex, that the reality of that is that there has been an impact because of a program, and there will always be an impact when you have a fee schedule program of some point. I'll hand over to Todd because I know he has specific things that he feels about that New York implementation.
Well, thank you, Jonathan. I think the point with New York is they adopted a tool for pricing bills that was a proprietary tool, and you have to pay to use it. I've always been of the belief that if a state is going to regulate, expect shareholders to follow a regulation, access to the tools should be at no cost whatsoever. The other way was the way it was implemented. It was implemented very quickly, very little advance notice. And I don't know that there's been any studies to show that that tool actually does a better job than the other cost containment mechanisms out there for those same type costs. So all in all, I just think it was a poor implementation, and it hasn't proven that it's a much greater cost savings than the other states.
Thanks, Todd. If healthcare costs are increasing, why are rate filings going down across the country?
One of the things that we talked about was losses, right? Losses are actually happening. And one of the things that you've seen happen consistently since 2008 is a reduction in the total filings that are happening. When the financial crisis happened, there was a significant reduction in the number of cases that were actually filed. So medical cost represents 50% of the total losses, but at the end of 60% now. But at the end of the day, if there are less losses in total, that leads to an overall reduction in what's happening with those filings.
A couple more here. Do all states use codes and RVU, RVRVS from the prior year? What are the benefits and drawbacks in using the prior year codes?
No, most states don't use the prior year. Most states use current data. The benefit of using current data is that you have codes that have been deleted and should no longer be used can't be used. And the codes that have been added, and there is a large amount of codes being added each year, they can be used and they will have set values. So no, I think most states, there are some states, most states use current. There are some states that will use 1 or 2 year behind on the RVU or the RVRVS data. But I don't see that as a benefit because of the new, because new codes and deleted codes come into play.
And then one more before we move on to the next section. With the increasing number of updates, what is a reasonable industry expectation for the time the schedule is released until my bill review vendor has it loaded in production?
Assuming that the information that they released has a future effective date, the industry standard is 15 to 20 days for data and more of a 30, 45, 60 days for rates or rules. And the reason the rules take longer is because you're looking at programming changes. So there's more interaction on the bill review side where there's development, there's quality assurance, higher quality assurance to make sure those rules are put in place properly. The rates can be put out more quickly because it is just data.
Got it. Thanks, Lisa. All right, Jonathan, I think make sure we save enough time. I'll send it to you for section 3.
So if you're analyzing your current program, what are the things you should consider, and what tools do we have out there that will help you stay up to date? If I look at the things which are, you should consider in your program, one of the first things is, are providers complaining? I will be the first to say that a provider complaining is not an indication that that provider is always correct. But if you have an increase in volume in provider complaints, that may be an indication that there is something that is not being done correctly within your system. Now, the issue there is that you need to make sure that you address those and make sure that it's being done correctly. As I mentioned, if our providers complaining may not be the be all and end all. So really what I want to know is, in my bill review system, can I identify reconsiderations that are due to fee schedule challenges? So if somebody's saying, hey, I have a problem here, you should have paid me more, how often do I actually make that additional payment? Being able to identify and track those things is a good indicator of what's really going on in your system. Another thing that I would want to look at is how often are you required to manually intervene to appropriately apply a fee schedule or rate? Are there some things that you cannot do in your system? One of the things, even if you're not doing this yourself, so it doesn't have an operational impact on you, one of the things that's important about that is every time you manually intervene, as opposed to doing it through an automation, that leads to inconsistency and inaccurate application in some circumstances. So obviously a key thing there is making sure that everything is done automated whenever possible. The next thing I would look at is we talked about SLAs. We just had that question, good question. Do you have SLAs for loading your fee schedules? Are there different ones for rates and rules? Do you get regular reports on that? If you do get regular reports on that, what information is in there? My favorite anti-statistical comment is always that averages can hide a lot. If you look at what happens with averages, you can have numbers that may appear to show that you're doing really well, but how often are things actually done outside of that SLA, but the average overall hides it? One of the things that you want to look at in that situation is, as Todd said, if most of the things are coming in January and July, don't expect 100%. But are things being done in a way that allow you to accurately address things? Are they being done in a way that you're not getting late payments, you're not getting all of those kinds of things because of delays in implementing fee schedules? And finally, the thing that I look at is, can you influence regulators to fill in their fee schedule gaps? Can you get your employers to do that? Are those the things that you can do? Are you getting help from that with your vendors? Todd, would you like to talk about some of the tools that are out there to allow us to monitor things?
Certainly would, Jonathan. We have a variety of tools we use. One of the tools we have is legislative reports. Starting in January, those reports go out every month. Typically, there's 3 reports that go out. Bills that were introduced during the month, bills that are active, and for me, active means it's passed one of the chambers and is sitting in the other chamber. And the last report is an active. An active is a cumulative report that basically provides you with every bill that's been enacted during the calendar year. That tool that we have is available. See below, just email me, tbrown@meddata.com, and we can add you to the distribution list. The important thing here is that a lot of people don't consider legislation until after it's passed. This allows you to stay ahead of the curve and work with the states as they're working on things going forward. Another tool we have is what we call the link. The link is updated monthly. It contains information on fee schedule updates, when they were occurred, when they were put into place, regulatory news. This basically is a summary of our regulatory bulletin that goes out daily. It talks about rule changes. It talks about proposed changes, adopted changes. It really drills down on the regulatory side, not just in medical. We note any changes that are happening with claims and other factors in the workers' comp arena, because we fully understand that medical is but one piece of what our our clients and customers and staff need to be aware of that's going on in the industry. And then you can actually drill down to the activity by state. In other words, you can go in and if all you care about is North Dakota, you could drill down and just get information on North Dakota. Or if you're just in a couple states. And again, this is something that while we developed it and do it primarily for clients and staff, it's available to anybody. You can see down below if you register at meddata.com, the link, you can sign up to have access to that product. And finally, a product that I think is extremely beneficial is our lookup. Basically what lookup does, it allows you to take any CPT code and look up the fee for that CPT code in any jurisdiction. And what may return, if it's a state that has Medicare, it return Medicare jurisdiction. If it's a state that has fee schedule, it return fee schedule jurisdiction, plus the Medicare payment for that, as well as UCR. And I think this is particularly beneficial, obviously, for the Medicare set-aside program, but particularly if you're looking at a state that doesn't have a fee schedule and you want to get an idea of maybe what is a good amount to pay, you could look at several surrounding states to get an idea of what that marketplace, that area bears. One of the critical things for this is to have a very valid and up-to-date UCR process. Again, that's something that we take a lot of pride in is our UCR. It stays up to date. It is rolled currently. And again, this is a product that would be available. You can go in and sign up for free on at the website. And so those are the tools we think are important.
Thanks, Todd. Appreciate you relaying that. Just going to finish up with a few questions here. How do fee schedules affect PPO utilization?
So now typically fee schedules are not going to impact the PPO utilization. Reality of that is that there are several other things that impact that, but it is a really important question. We should think about the impact of fee schedules on how PPO fees are calculated. If you have a bill review system that's not driving to the correct fee schedule, typically what happens is you end up paying a set rate for your PPO. That's going to mean that you're paying more PPO fees too. So that's a really important thing to think about. The PPO on top of the fee schedule can actually drive you to pay more fees if the fee schedule is not accurately calculated.
How many states have timelines for payments and penalties for payment timeliness?
Yeah, just about, let me just say, every state has requirements that you have to pay a bill within a certain time. Depending on the state, average is sort of 30 days, but there can be 45. 2 states that have developed electronic billing have required you to pay those bills within 15 days if they're received electronically. In terms of penalties, that really, again, depends on the state. You take a state like California, if you pay late, you add the penalty and the interest and send it out with the payment. Other states, when they do audits or when you report to the state, will fine you X amount of dollars. For a lot of states, they really don't monitor that very closely. Typically, state reporting states look at that closer, but most, while they have that requirement, there's not a lot of enforcement across the country on the timely payment of bills.
And the interesting thing about that, just from the broader perspective, is that we saw earlier that almost 50% of the fee schedules were released late. You should be looking at how effective your bill review vendor is at getting those changes in, but also what opportunities they have to prevent you from issuing incorrect payments, but being able to make sure that you still control those. So for example, if the issue is I'm going to get bills in, I need to update these specific rates, can you delay those payments and have them ready to go in a scenario that will prevent you from getting any of those fees, but still issue the payment correctly?
I'd like to point out too that an interesting case is Michigan. they have a 3% penalty for late bills, anything paid after 30 days. What they did in their hospital fee schedule is they built into that penalty into the fee schedule payment. So if you pay later than your hospital bills later than 30 days, you have to pay the 3% as part of that fee schedule rate. That's a very unique situation.
Earlier, we pointed out the huge number of changes needing to be made. How do companies keep track of that?
Well, I obviously there are tools out there you can use, obviously. But in reality, you just need to have staff that are going out and checking those websites regularly. We do it daily, but weekly, bi-weekly, you need to be checking those. You need to develop good relations with the states, and that can be done either with phone calls and hooking up with them, checking with them regularly, being involved with organizations like the IAIBC, where you can network with the state regulators. Again, it's a variety of things you have to do to stay on top of the game. And there's not any one thing. There's some good tools, but those tools sometimes miss. So it's really a matter of just a focus on making sure that you're aware of what's changing out there.
I think the other thing about that is that, the reality of it is it an actual priority for the organization that is handling that for you? Here at MedData, it is an absolute priority for us. As Todd pointed out earlier, when January and July happen, that's where we're focusing, because that's when the primary changes are happening. And it should be for a vendor who is providing those services, it should be absolutely their main priority is in making sure that those fee schedules are done correctly and updated correctly, accurately, and quickly. So one of the things to make sure of when you're looking at what's happening today is that a priority for your vendor?
Providers are a critical partner in the comp process, more so than any other line of insurance. They should be fairly paid, but how do we know that we are setting rates to attract quality doctors while also assuring we are appropriately controlling costs?
I think there's several things that can be done. You can monitor yourself, but really states are the ones that need to be monitoring it. And really the way you do that is you set your fees, you know how many doctors you have participating. When the fees become unsustainable, you will see the percent of doctors in the state dropping out. And I know one of the states I was at, we used that to determine when we needed to really take a close look and make adjustments to our fees. So it is a process. It's a delicate balance to make sure you're paying appropriately, not overpaying, and making sure you're keeping the good doctors in the system.
Alex, in addition to that, I think the reality of this is we have to remember that the providers are part of the whole overall process. So when a state puts a fee schedule in place, the medical community is part of that communication and part of that decisioning. They have lobbyists out there in the same way that the employer and insurance industry does. That's all going to make sure that those rates are done appropriately. Right. The New York example we showed a significant increase over Medicare to the New York fee schedule. If you go back and look at when Illinois implemented, they implemented at significantly higher rates because their objective was to control from where they were, not drive down rates down to a ridiculous level. And that's what needs to happen across the country.
Are there any good policies out there for fraud and/or penalties for fraud? Do any states follow the Stark Law, anti-kickback, etc.?
Sorry, go ahead, Todd.
There are several states that have enhanced their statutes recently regarding fraud. It is something that's on everybody's plate. Several states over the last several years have increased staffing for that, have set up units for that. I don't think there's that many that have gone with the thing that you mentioned, but it is certainly something on the state radars of the legislators. and they have been active in the last 4 or 5 years of enhancing their fraud capabilities, fraud detection.
Yeah, like Todd, I'm not aware of anybody who's implemented specifically around those laws. But if you take a look at what California's done, for example, over the last 4 or 5 years, they've done a lot of data and analytical work on trying to find the fraud within the system.
One last question here as we're getting towards the end. This has been a very helpful, very informative, and shows just how complex bill review is getting. Consequently, if there's one thing I should do, what would that one thing be?
I would make sure that your vendor is doing the right thing, getting the fee schedules up to date on timely and appropriately and accurately.
I would say stay informed, educate yourself as much as you can.
I would say interact with the states as much as you can, because what may be an issue for you is not an issue for them, and you need to be aware where they're heading and what are their concerns. So I would want to stay in touch with the states and those organizations.
Awesome. Thanks, guys, for answering those questions. That brings us to the end of today's webinar, our 2021 perspective on fee schedules. Thank you to our presenters, Jonathan Nutt, Todd Brown, and Lisa Andriozzi. If you have any questions that we didn't get to or think of new questions, please email the medatacorporate@medata.com link. And again, please be on the lookout for our future webinars coming down the line later this year. On behalf of Medata, thank you for joining us today, and we hope you have a great rest of your day.